just had this conversation with a patient about diabetes versus HIV, which would they prefer to have? I mean, not really prefer. But the interesting thing is that in 2019, it is so much easier to treat HIV than diabetes. In fact, I tell patients that HIV, if untreated, is one of the most terrible diseases that we can imagine. But if you treat it, people can probably live a normal lifespan. We know what causes HIV, and the medication we have to fight it is quite effective. But diabetes, we don't know what really causes it, and we're really treating more the effects of diabetes than diabetes itself sometimes. And it requires behavioral modification on the part of the patient, dietary changes, that sort of thing, which many people can't do. And diabetes can have terrible consequences, like cardiovascular disease, amputations from peripheral vascular disease, kidney failure, that sort of thing. So diabetes is a terrible disease. In fact, I hate it sometimes because it's so hard to treat. But HIV, oddly, is so easy to treat. And these days, you can treat it with one pill for many people. So in answer to the question about that, I think in some ways I prefer treating HIV than diabetes. I've been treating people with HIV since the early 1980s. And by coincidence, my career started when HIV began. So I was an intern in family practice in 1981, and shortly thereafter, I started in June of 1981. Shortly thereafter, there were the first reports of this unusual disease, which came to be known as HIV/AIDS. I had no idea that I'd be involved with this. I didn't know if I would ever see a case at the time. Of course, being a gay man myself, I wasn't sure if I was at risk. So, but by a coincidence, really, we began to start seeing people with HIV. No one wanted to take care of these people, and my business partner, Thomas Klein, and I just started to see patients because no one else would do it. And that's how it all began. Yeah, I'm publishing a memoir. It's being published by the University of Chicago Press in May of 2020. It's called Plague Years, A Doctor's Journey Through the AIDS Crisis. This is something I've been thinking about for many, many years. There have been books written about HIV, obviously. Some quite prominent people have written books about this disease. I didn't think there was necessarily a room for another memoir, but many years have passed since most of these books have been published, and HIV has changed. I mean, most of the books that have been published about HIV have been published before the mid-1990s. And although AIDS is still here, it's changed. And so I thought young people especially don't have much knowledge of HIV/AIDS, and even those people who are taking PrEP, which is the pre-exposure prophylaxis against HIV, have not experienced HIV themselves, do not know anybody who's had HIV/AIDS, and don't always know how awful a disease it can be. And I thought there was room for another memoir about this infection. In terms of being a primary care practitioner, most primary care practitioners are not going to be taking care of people with HIV. I happen to be a primary care practitioner, and the only reason why I'm doing this is that I got swept up in the epidemic at the very beginning. But I think most people today who are primary care practitioners are not going to be taking care of people with HIV because you have to have an expertise in doing it. You have to see a lot of people with that disease to feel comfortable taking care of them. So most people these days are being followed by infectious disease specialists who have more experience. But that said, there's still a number of us who've been doing this for for decades that will continue to do this until we retire. But so I'm trying to answer that question indirectly. It has no bearing on me as a primary care practitioner, but as a specialist, it allows us to have a wide range of medications to prescribe to people. So today, unless someone really messes up their treatment plan, there's no reason why we can't find a regimen that should work. So we have, as you say, 45 medications or so that can be used to treat people. HIV there's no reason someone should remain detectable. That is, the virus should be totally suppressed by whatever regimen we choose to find, if that makes sense. Yeah, how we treat people with HIV has evolved, obviously, over the decades. Initially, in the 1980s, we had nothing to give people. Then AZT became available, and we were using what was so-called monotherapy, like one drug at a time to treat someone. That turned out to be ineffective. And then by the mid-1990s, we suddenly had these so-called cocktails, which were multiple, like minimum of 3 medications that one could use to treat HIV, modeled on treating tuberculosis, which is also treated with 3 drugs. So suddenly we had medications that we could use that were very effective at controlling HIV. So, and since that time, the treatment has become even simpler. People used to take 15, 20 pills, not only for their HIV, but to prevent opportunistic infections, as they're called. But now we actually have, for most people, we can find a single tablet, which is pretty remarkable. I remember having a patient tell me that he couldn't believe it. He said, this just doesn't seem right to me. One pill, how could that be? But it's true that we can now, for many people, just do a single tablet regimen, simplify their treatments. The side effects are very few. So people can be on these medications for decades and not have any significant side effects whatsoever. Whereas the older medications were not only burdensome, but also had some unpleasant side effects in some people. In terms of adherence is a very important issue for management of HIV. Why would someone not adhere to their regimen? One reason is that if someone's very young and they have not had experience with people who've died of HIV, have not experienced some of the consequences of untreated HIV, they may not be as motivated to take the medication. They may be in denial of the severity of the disease, and therefore they may not take the medication on a regular basis. Sometimes people can't afford the medication for some reason. They have high copays, and they can't afford it, so they stop the medication. They may become depressed, and depression itself can sometimes lead to lack of adherence because people don't at that moment may want to just die for other reasons. There can also be lapses in insurance. So some people they are between insurance companies. They may not be able to get the medication. So there are multiple reasons why someone might not adhere fully to this regimen. And we're talking about something that, especially for the young person, is going to be 50, 60 years of their life, most likely. What is the idea behind PrEP? PrEP means pre-exposure prophylaxis. What this means is that we're trying to prevent HIV in people who are HIV negative. This is an idea we've been pursuing for many, many years. Obviously, before we had these medications available for this purpose, people were acquiring HIV because they were having unsafe sexual contact. Although people have been using condoms, it's been irregular, and so before PrEP was introduced, I was still seeing people who were newly infected with this disease. By great luck, one of the medications that we use to treat people with HIV has been very effective at prevention, as it turns out. It's called Truvada. It's two drugs combined into one. It's 2/3 of a treatment for HIV. So it's not sufficient to treat HIV, but it's very effective at preventing HIV in more than 90% of the people taking it. There is another medication that was just approved literally this last month called Descovy, which is an updated version of Truvada. Its safety profile is a little bit better, but it too is very effective at preventing HIV. So, what is the rationale for how do I introduce this to patients? Well, interestingly, a lot of people just introduce it to me. I don't even have to bring it up. That they know about this, and so they ask about it. But those people that I think should be on it who are not asking about it, and those people would include individuals who are getting other STIs or sexually transmitted infections. Those people are at great risk of getting HIV, so I very strongly urge them to go on it. And when it was first introduced in 2012, people were very reluctant to go on it. They didn't want to go on medication, especially a healthy person doesn't want to be on something that could potentially cause adverse effects. But I think, at least in the patients that I see, many of them have accepted this as being something very valuable and something that's worth doing. They're not afraid of the side effects so much. They're obviously more afraid of getting HIV than any of the rare side effects that might come from the medication. The problem with PrEP is that it is very expensive, just as the HIV medications themselves are also very expensive. The idea of PrEP has been embraced by the Center for Disease Control and Prevention and by the FDA. And so those two organizations have been pushing PrEP as a public health. It's for public health reasons more than anything else. So in many ways we can look at it as a vaccine, although it's not really a vaccine, but as a great tool for preventing HIV. So yes, it's very expensive. Most insurance companies do cover it. It's covered by Medicaid. If a person has a high copay, the drug company itself will pay for some of that. So most people, at least in the state of Illinois, I can't speak in other parts of the country, most people in Illinois should have access to the medication. There are also programs that can support people who don't make enough money to pay for the drugs, so the state will pay for it or other organizations will pay for it. Now, this is not a universal thing. There are states in this country that do not have those programs, or it's very hard for people to get access to PrEP. I know there's an article in the New York Times a couple months ago about people in Mississippi, for example, that cannot get the medication because it's just not on their formularies. So that's not only for PrEP, but it's also for HIV medications too. So access to medications, whether it's for HIV treatment or PrEP, varies unfortunately from state to state. And some states are much more generous than others in that regard. U equals U means undetectable equals untransmittable. And what that means is that if someone is taking their HIV medication properly and the viral levels are suppressed, they are not going to transmit this virus to other people. Now, a couple decades ago, maybe it was not that long ago, but the Swiss government had recommended that if people were undetectable, that they didn't have to use condoms anymore with sex, and this caused a huge uproar. And statisticians calculated that there was still a risk of people transmitting, of someone being on medication and still transmitting the virus to other people. But the reality is that's very rare. I think the lesson to be taken from this is that if you are having multiple sexual partners and your partner tells you, I have HIV, I'm on medication, I'm suppressed, I'm not going to transmit it to you, I think you should take that not with a grain of salt, but you should be a little bit skeptical. But if you're in a monogamous relationship where one person is positive, the other one's negative, the risk of transmitting that virus to the negative person is virtually zero. So in that setting, it's U equals U. In the reality, you just don't know what your other partner's status really is, so you should still use PrEP if you're at risk. But the truth is, though, if you really are undetectable, you're not going to transmit this virus. Well, HIV is a chronic infection. That is, it's something that stays with someone for life. There are people that have other complicating factors that make them more at risk for developing other problems. In particular, African American men or men of color. It's not so much that they are that they're more susceptible to HIV itself or to its consequences, but oftentimes these individuals have other chronic problems. They may be diabetic, they have problems with hypertension, high blood pressure, other chronic problems that interfere with that will reduce their morbidity or increase their morbidity and mortality. So it's not HIV itself. I mean, HIV is if it's treated and people are doing well, it's not going to cause a problem. But the other problems are going to take over. So, for example, I have a number of patients with diabetes, and these are men with HIV. They're African American. They take their medication. They've been undetectable. Their HIV is in complete control. But unfortunately, they develop diabetes, and they've developed the consequences of diabetes. Two I can think of right off the top of my head are on dialysis. One's had two amputations. I mean, these are horrible consequences, but they have absolutely nothing to do with HIV. So there's that. Now, there could also be populations of people that just don't have access to HIV medication, and if their HIV is not treated or controlled, that could be a complicating factor along with diabetes and hypertension. So it's not that people of color are innately more at risk for complications of HIV. It depends on other factors. HIV medications work beautifully no matter who you are. You have to have access to them and you have to take them. But that aside, there are other complicating factors, as you say, socioeconomic factors or other health factors that can reduce life expectancies in other populations that have nothing to do with HIV itself. Well, I think that when we look at the differences between the white population and people of color, what kind of differences are we talking about? Some are biological, there's some biological factors, but generally it's going to be socioeconomic. Or if you don't have access to medication, for example, you're going to have more, for HIV medication, you're going to have more complications from HIV, obviously. So one solution is to try to create universal access. Now, this probably has to be done on a federal level because state to state there's so much variation. I don't know how that's going to happen, but that would be one way of dealing with it. The other is access to care. So if people are in rural communities and don't have access to regular care, they have to travel hundreds of miles to get it. That's going to be a deterrent. So somehow getting people to have greater access to care is going to be crucial. Making medications, the affordability of medications is sort of an artificial issue in a way, because it's determined not simply by the pharmaceutical company, but it's also determined by what insurance companies will pay. So that's an issue that is something that is sort of a little bit opaque in terms of how to manage it. So people say, well, if the drugs are $3,000 a month, that's a lot of money, but $1,500 a month is a lot of money too. So we're not talking about terrific differences in cost between various HIV medications. They're all very expensive. but being able to ensure that people get access to them is critical. So. HIV is a sexually transmitted disease. It's like gonorrhea, it's like syphilis, it's like chlamydia, it's like herpes. These are diseases that have been around for for centuries, perhaps thousands of years. So sexually transmitted diseases themselves are just not going to go away. HIV, the only way HIV would go away totally is if we somehow had a vaccine that prevented it. But that would require a type of diligence that we haven't been able to solve with polio, for example. I mean, polio is a disease that we should theoretically be able to to expunge, but we still can't do it. So being a sexually transmitted disease, HIV will always be around. Now, that doesn't mean that it's going to kill people. If we have adequate treatments for it or preventive therapies, I mean, HIV will not cause long-term problems for people. But like any STI, it's going to be around. It probably will not go away. I think I'm optimistic about HIV treatment because over the decades, it's gone from no treatment to amazing treatments. I think even if people have to take a single pill for the rest of their lives, that's pretty miraculous because you've taken a universally fatal disease and turned it into a chronic infection, and not just simply a chronic infection, but one that has almost no physical consequences. People are just doing beautifully on these treatments, and most of whom can live a normal lifespan. So that to me that itself is optimistic. Is there going to be a cure? I don't know. I would never say it's impossible. In the 19th century, people thought they could find a cure for tuberculosis, or other people thought it couldn't happen. But 80 years later, there's a cure. I mean, so to sit here today and say there will never be a cure for HIV would be folly. But what form that will take, I don't know. But research continues. There's not a flagging in people being interested in trying to solve this problem. And so I feel optimistic that at some point something will be found that will eradicate this virus. Relying simply on treating people who are infected and depending on people who are at risk going on PrEP is not sufficient to stop this epidemic. But in theory, it could be stopped if everybody infected took their medicine, everybody at risk took medicine also, but that's just not going to happen. But I think that given the advances in science, I think someone or some people are going to find some ultimate solution for this problem. I think in terms of what new things I would like to see in the future, obviously I want to see a cure. I mean, that's what I really want.
Sure.
I think anything up to that point is inadequate. So there will be different treatment modalities. Like there's some talk about giving injections to people with HIV so that they can take medication every 3 months or once a year. That's just a variation on the theme. People still have to take medication. So to me, until there's really a cure, we're not going to see any great advances. We'll see some tweaking of our treatments and maybe fewer and fewer side effects, but I don't see any, to me, nothing is going to be equal to a cure.